time, I'll request our next speaker, Dr. Neha Midha. She is the director at Avantika Eye Care and Glaucoma Services Center. She is going to enrich us about arresting pediatric myopia and the ideal prescription methodology.
Good morning, everybody. So I'll be talking about the arresting pediatric myopia. Although this is a very extensive topic, I have tried to make it very, very concise. So let's begin with it. How big is the problem of myopia? So in 2000, we expected about 165 million people to be myopic in the world, whereas by 2050, this number is supposed to go up by 4,758 million myopes all around the globe. Now, what are the various proposed theories? The first one being the genetic inheritance, although various other genes are also, postulated to play a role. But parental inheritance is one of the most important things that we need to take care of when the patient is walking into our clinic. So if both parents have glasses, the chances of child getting myopia is about 3 times. Various socioeconomic factors like higher levels of education, private schools, urban living, constricted living spaces, girls, since they have a less tendency to go out and play. So in these cases, higher tendency of myopia is seen, increased near activity and lack of outdoor activity. So now, what are the possible interventions to arrest myopia? So one is the new myopia control glasses, contact lenses, lifestyle changes, and pharmacological. We'll just take up each one of these one by one. So before we get into the optical treatment, it is very important to understand what is hyperopic defocus, the term which is being very rampantly being talked about these days. So what happens is when you are correcting myopia with your normal glasses, do we have a pointer? Okay. Normal glasses, so in the center at the fovea, your image is exactly forming at the fovea. However, with the conventional glasses, in the periphery, the image is forming behind the retina, thus causing a hyperopic defocus. So what does that do? So when you use these special glasses, which are made of special lenslets, thank you. So when we're using these special glasses, so what happens is instead of conventional glasses where this image was in an uncorrected myopia, all this image is in the front of the fovea and these are outside. When you correct them with normal glasses, this still remains outside. Whereas when you correct this with these myopia control glasses, even the peripheral image is now being formed at the retina, thus decreasing the hyperopic defocus. Why this is important? This is because the stimulus for the axial length to increase, for the myopia to increase, is blur. So whenever our brain perceives that the image is forming behind the retina, there is a signal that goes down that eyeball needs to grow. Eyeball needs to enlarge in size so that even this peripheral image falls on the retina. This blur is responsible for the axial elongation and your increase in myopia. So these glasses are typically meant to take care of that. These are currently being marketed by Essilor and Hoya. Hoya ones are now being available in India also very commonly. A pair of glasses costs you about 15,000 rupees. So in patients in whom you feel there is accommodative lag, progressive addition lenses, bifocal lenses have also been used, but not with that great success. Earlier there was a belief that we should be under-correcting myopia. However, this is being now challenged. Yes, overcorrection is not expected, but adequate correction of myopia is required for proper control. We should not be under-correcting myopia. And for these, as I just discussed, these special myopia control glasses are expensive and cost and availability is a limiting factor in Indian scenario. Coming to contact lenses, again so in contact lenses, the olden one is the orthokeratology, in which with no lens, this is the myopic cornea. When you fit the lens at night, this is how it is looking, and after overnight adjustment, there is reshaping of the cornea that you can see. Then in the daytime, the patient takes off the contact lens, but still maintains that shape and does not need to wear glasses during the daytime. So this is the concept of orthokeratology, and it is known that it is shown to decrease myopia progression by 45%. Then moving to the more advanced methods are multifocal contact lenses, and one such being commercially available is by Cooper Vision, that is goes by the name of MeSight. And again, it is working on the same concept of correcting the hyperopic defocus. However, what are the limiting factors here? Hygiene issues. We need to teach the child very well. Availability in India is still a concern. People are getting it from outside who can afford it. Then moving on to the pharmacological treatment. So various drugs have been tried over time, but only low dose atropine has made its mark. So various studies have come throughout the years showing the benefits of atropine. So the first study that came, Atom 1, I'm just telling you in brief about the study. It said that 1% atropine is effective in controlling myopia. Then came Atom 2, there were side effects of 0.01 atropine, 1% atropine. So they thought of reducing the dose, and they compared some doses and they found that 0.01% atropine was good for controlling myopia, but axial length elongation was still happening. So that was a concern. Then it was the LAMP 1 study, which showed that 0.05% atropine is best in controlling myopia also and controlling your axial length elongation also. LAMP 2, that was the final phase of the study, also said that 0.05% atropine is the best strength by all means, and its effect is double as compared to 0.01% atropine, and it decreases myopia progression by 64.5%. So yes, the studies do say that 0.05% is the ideal concentration. However, it is still not commercially available, and we can start with 0.01%. So important here is that it's not uncommon for me to see that people are coming and with prescribed low dose atropine in any kind of refractive error. The concept has come that you give it in any kind of refractive error and it will help, but it is not the case. It is only useful in simple school myopia. You see a 4-year child with minus 11 diopter sphere, that is congenital myopia, your atropine is not working there, so do not give. Patients who are coming with minus 4 diopter cylinder at 5 years of age, there is no use of giving low dose atropine there. So the prescribing schedule is 1 drop once at night for 2 years for children less than 16 years of age. You have to, hammer it into the head of the parents that if you leave the drop in between, there will be a rebound and the myopia will increase even with further speed. I typically tell them to buy, a stock of at least 6 months. There should not be a gap. I tell them, if you can't do good to the child by putting drops, do not do bad to your child by missing the drops or, discontinuing the therapy. So explaining about compliance is extremely important. Also, it is a very common mistake that you write atropine. They do not care to see that what strength they are buying. They see, oh, what madam had written was for 200 rupees. This guy is giving it to me for 30 rupees. So I typically explain them कि 30 रुपए वाला नहीं लेना है, 200 रुपए वाला लेना है. That is what is required. Okay, so not all myopes will respond to your low dose atropine. So what you have to do when you see your patient has already been using atropine for 1 year now, but still you see that the myopia is progressing. So first is to check compliance. Are they actually using it or not? What is the method of drop instillation? Second theory that has been proposed, that if you shift the child from HS dosing to once morning dosing, somehow the results improve, they respond better. Even if you feel you have shifted to morning dose and still there is not enough response, the child is still progressing, you have to shift the child to BD dosing from 0.01% once at night and once in morning. And if you still feel, or either instead of doing BD dosing, you can also increase the strength to 0.05%. People are using 0.1% also, and in fact 1% also, along with bifocal lenses. So it depends how fast your myopia is progressing, and you can adjust your dosage accordingly. Then coming to lifestyle changes. So you have the counseling time that you have to give. You have to decrease screen time to less than 30 minutes per day on phone. That's what I recommend. Switch to bigger screens from phone to iPads, and iPads to TV. Online classes, if they want to watch YouTube, please watch it on TV, not on mobile phone. Enroll in toy library, book library. We just tell the parents that do not give phone to them, but then what to do? You have to give the parents as well as doctors, you have to tell them what to do if you're not giving them phone. And Then outdoor activity of approximately 14 hours per week has shown to significantly decrease myopia progression by 33%. And if not 14 hours, then at least 1 hour per day is highly recommended. Going to a sports complex, playing at night time is not helpful. That play has to be during the daytime. And I tell that even, going on the terrace is also a good enough. So just the take-home messages: choose your correct patient in terms of age, refractive error, progression, parental history. One or more methods of myopia control can be combined. You have to ensure and reinforce compliance. Affordability of these modalities has to be kept in mind. And outdoor play, do not underestimate its holistic benefits. Thank you.
Thank you, Dr. Neha. Thank you so much. In the interest of time, I'll request Dr. Talveer to take up the stage, and the questions can be addressed by Dr. Neha from the table itself. One question I wanted to ask you was that what will you recommend for somewhere a 6 or 7 year old child coming to you with that -2, -3 kind of myopia? What will be your first line of treatment?
Yeah. So the first thing is that when on my first visit, I would not prescribe atropine. I would we observe the child for 6 to 8 months. You see if the child is actually progressing. If you see even a 0.25 diopter progression, then I will start the child on 0.01% low dose atropine once at night. That will be my initial thing. If parents can afford, I will put the child on